the abstract on potential value of lateral-flow urine LAM test for TB diagnosis in children with severe acute malnutrition. And the presentation is by Birgit Schramm, epidemiologist from the Epicentre. The floor is yours, Birgit.
Thank you, Alexandra. Good morning, everyone. Thank you for the opportunity to present today the findings of our proof of concept study, which explored whether the lateral flow urine LAM test may have a role in TB diagnosis among children with severe acute malnutrition. Next slide. So why in some children? We know that TB is a serious comorbidity for children with SAM, and malnutrition also increases the risk of TB mortality. And at the same time, TB diagnosis in children is particularly challenging, and we lack simple diagnostic tools for better integrating TB diagnosis also in malnutrition wards. So since 2013, we have this point of care assay available that was already mentioned this morning. The LAM antigen, the LAM test that detects the LAM antigen of MTB in urine specimens, which are easy to collect also for small children. And as of today, this test is only recommended in HIV positive clinical populations, mainly since it performs best among those severely immunocompromised. At the same time, we still have very little evidence of LAM testing in pediatric populations. So here we hypothesized that the LAM test may also have a diagnostic value in mainly HIV negative SAM children, considering that immune dysfunction can also be found in association with malnutrition. Next slide. So we specifically used the determine LAM test, a lateral flow test that provides the result within 25 minutes. The readout is visual. If the sample is positive, there will be a band appearing in the patient window. And with determine, the test distinguishes 4 intensity grades for a positive test, which are reported with help of a reference card. So this picture shows an example of grade 3 positive LAM result. Please excuse, there's a typing error in the figure legend. And according to the manufacturer, any grade 1 to 4 is reported as LAM positive. So the final result is either negative or LAM positive. Next slide. The objective of our study was to assess the prevalence of LAM positivity in the context of TB diagnosis among some children. And the study was conducted in the MSF-supported intensive therapeutic feeding center in Madawa, Niger, where malnutrition is highly prevalent and TB is endemic. In this cross-sectional study, we included children under 5 years hospitalized with SAM into 2 separate groups. Group 1, children presenting with at least 1 sign or symptom of TB, which was our main group of interest. And group 2, children without any sign or symptom of TB, nor a history of fever or pneumonia, which was our control group. And we aimed to include 100 into each group. And LAM results were only used for study purpose, so clinicians had no access to the results. Next slide. So in both groups, included children were mostly, almost exclusively infants below 48 months, and only in group 1, 2 children tested HIV positive, which is consistent with the low HIV prevalence setting. And if we focus now on the right side, group 1, those with signs and symptoms of TB, 14.7% were reported being a contact of an active TB case. And it's also important to point out that programmatic TB diagnosis here was largely based on clinical presentation. Only 43 of the 102 included children were receiving a chest X-ray, and 55.8% of these had an image suggestive of TB. And only 7 children here received a GenExpert test using a nasopharyngeal aspiration. Among those, 2 had MTB confirmed. So overall, in group 1, 22 children, corresponding to 21.6%, were initiated on TB treatment. Also worth mentioning is that in-hospital mortality in group 1 was very high, 19.6% died during hospitalization. In our control group on the right side, among 100 included children, none was diagnosed with TB and none died during hospitalization. Next. So depicted here now is the core of our study, the LAM test results obtained in each group. And actually, much to our surprise, we found a high proportion of LAM positive not only in group 1, 51.7%, but also in group 2, 37%. So however, if we break down positive results by LAM intensity grades, grade 1, the lowest positivity, was similarly high in the two groups, shown in blue here, 37% and 36%, while higher than grade 1 were almost exclusively detected in group 1 with a prevalence of 14.7% compared to only 1% in group 2. So given this high proportion of almost exclusively grade 1 positive in our control group, we considered that grade 1 LAM results are not useful in our population and may actually largely represent false positives. Next. So in the next step, we conducted a sub-analysis to assess the diagnostic yield among the 22 children in group 1 that were initiated on TB treatment, considered probable TB cases. And we assessed the negative detection rate among all children in group 2, which we considered unlikely TB cases. And importantly here, we considered only LAM grades higher than 1 as positive. So in this sub-analysis provided a much more encouraging picture. The LAM tested detected at least 1 in 5, corresponding to 22.7% of the probable TB cases on the left, while the negative detection rate among unlikely TB cases was 99%. Next. So taken together, we conclude that LAM urine testing may have a potential value in diagnosing TB among HIV-negative children with SAM, who are currently excluded from testing recommendations. While the determine grade 1 result may not be useful to diagnose TB in this population, grades higher than 1 may identify at least a proportion of SAM children with TB who could then benefit from rapid treatment initiation. So while clearly a limitation of this study was the absence of a systematic reference standard to diagnose TB, we believe the findings are very encouraging and really call for further diagnostic performance studies in HIV-negative SAM children who are currently not benefiting from LAM testing, and that should also be incorporated in studies now going on for new generation LAM tests that are becoming available. And next, thank you to everyone involved in the study, and thank you very much for your attention.
So sticking with TB, we have one oral abstract coming from Shilpa Ravi, who is with MSF based in Mumbai, and we're moving from diagnosis to treatment in COVID times. And she's going to talk to us about using the new drugs for treating TB in Mumbai during COVID. So I'm going to hand over to Shilpa.
Thank you so much. So a very good morning to all of you, and welcome to today's presentation. So I'm going to be talking about our experience of using all oral regimens and newer drugs for children with drug-resistant TB. And this was implemented during the pandemic of COVID-19 last year in Mumbai, India. Next slide, please. Okay, so in India, we have been providing conventional 20 to 22 months of treatment for MDR TB, and most of the regimens consist of injectables. Also, since 2018, injectable containing shorter regimens for 9 to 12 months was introduced for MDR TB patients. All the injectables to the patients are administered by private practitioners and local clinics in the community. As a result of the COVID-19 pandemic and lockdown, this service, which was used by private practitioners, could not be accessed. Additionally, a lot of the normal government hospitals were converted into COVID clinics and centers, because of which patients could not access this service. Apart from that, recently, delaminate has also been approved for use in children, and that was the reason it was able to constitute an all-oral regimen which was free of injections. The context where MSF works in Mumbai is in a ward called as the M East ward, which is one of the most high burden wards, both for drug sensitive and drug resistant TB. We have a population of around 8.5 lakh, and the population is in a very overcrowded community in a slum area, which has a more chance of spread of TB. So a lot of our infections are both primary and secondary MDR TB. So the main people who work is we are working in a collaboration with the National TB Elimination Program. And the team is a big team which consists of doctors, nurses, psychologists, counselors, social workers, peer educators. We also provide psychosocial support to children, and all the treatment regimens are provided based on the drug susceptibility testing through an ambulatory care program following the National TB Program guidelines. Next slide, please. Yeah, so the objective of this study was to identify the proportion of children who were initiated with all oral regimens and newer drugs in 2020 compared to 2019. So if you look at our overall cohort of patients at this area, among the total 835 patients who are initiated every year on drug-resistant TB treatment, we have about 22% which are children up to 17 years of age. So this is one of the biggest cohorts of pediatric DRTB. And among the 183 children who were actually initiated last year, a major chunk of our children are having MDR TB and pre-XDR, which is predominantly fluoroquinolone or second-line injectable resistance. In fact, the proportion of fluoroquinolone resistance in our cohort is about 45 to 47%, which is extremely high. Followed by this, you have XDR, which is resistance to both fluoroquinolone and second-line injectable, which constitute about 9% of our cohort. So when you compare the proportion of children initiated from 2020 to 2019, you can see that about 75% of children were initiated on an all-oral injection-free regimens last year when compared to 33% in 2019. The proportion of children started on newer drug-based regimens, that is bedaquiline and delaminate, was also significantly higher, which was 33 to 15 and 25 to 9. We have also been able to start patients on a combination of bedaquiline and delaminate for those children who had an extremely advanced resistant profile and who could not be managed with just one of the new drugs. Next slide, please. So what are the main interventions we have done? During the pandemic, as a result, we have been able to start more children on all oral regimens. So we have seen that at the end of 6 months of follow-up of children who were initiated last year, 94% continue to be on treatment. We have had zero loss to follow-up of children last year in spite of the pandemic and lockdown, which has been a huge achievement for the team and the efforts they have done last year. Some of the important interventions which we focused on were, as soon as the pandemic and the lockdown was announced and we knew that patients could not visit the center or the clinic as often as they would want to, we started doing a lot of specific interventions like virtual counselings were done over the phone to improve patient adherence and to motivate them to continue their treatment. Support group meetings, especially for adolescent population, was held over phone. Phone-based contact tracing was also done by community health workers. So they used to call the patients. So if there was an index patient who was an adult, the patient was called and contact tracing was done over the phone. And if any child had symptoms, then they were asked to come to the clinic. Health education talks in the form of posters and videos were sent on the phone for both TB and COVID prevention. And the doctors actively participated in doing a telemedicine for managing mild and moderate ADRs. So any patient who had a grade 1 or a grade 2 adverse reaction were managed on the phone directly by, medications or any other home remedies. And only patients who actually needed to come to the hospital were asked to come as a result of the lockdown. Apart from that, post this experience, in October, we also started a dedicated pediatric OPD, which is a once-a-week OPD which runs for children, where all children are asked to come on that day and a systematic medical and psychosocial care is provided. The OPD has been transformed into a child-friendly space with posters of various cartoon characters being installed in different walls to improve engagement of children. Health education sessions are improved and modified in the form of short skits or dramas rather than just a one-way lecture. And also, one of the biggest way of motivating children is we are providing cartoon tattoos on their treatment calendars. So when a child completes their treatment, he comes for a monthly follow-up and he's been able to take all the treatment, a tattoo is given and it really makes the child happy. And we have also been continuing the monthly group meetings for adolescents. So these are some of the very innovative interventions which we have done, and it has been received really well by the children. Though it is very early to provide results on this, but our basic analysis of just speaking to patients and caregivers show that there has been a significant improvement in terms of motivation and happiness when the child comes. So their adherence levels are also seen to be improved. Next slide, please. So I think we would like to conclude by saying that the COVID-19 pandemic was actually a blessing in disguise for us. It has resulted in reduced access to administered injectables because closure of private clinics happened. So all the children had to be started on all oral injection-free regimens. All oral regimens are safe. It avoids painful injections. It also reduces the risk of severe adverse events like hearing loss, which is extremely common with certain injectables. So we definitely would like to advocate that all oral injection-free regimens should be given to all children with drug-resistant TB and across national programs in India. Thank you.
Fantastic. What a brilliant practical way of continuing TB treatment. I'm really inspired by what you managed to achieve under the pressure of a horrific pandemic. A question on how you did this telemedicine. You said you managed adverse reactions by phone and telemedicine. What did you tell the patients? How did it work? Did you actually see the child and so on?
Okay. So it in simple steps. So the counselor. So every counselor has a list of patients who are attached to them, and the counselor is very, very comfortable, and the patients have a good rapport with the counselor. So the counselor was given the responsibility to call the patients at the first level. The patients were called and the patients were asked whether they have had any side effects. That was noted down by the counselor. It could be something like a simple vomiting or loose motions, anything, any of the simple adverse events were noted down. After that, that list was shared with the doctor, and then the doctor did a second line of calling to the patients to identify what grade of adverse event it was. If it was a vomiting, which was just grade 1, which just needed maybe an oral rehydration solution, or maybe just, some increased amount of liquids, that could be managed. Apart from that, a lot of auxiliary medications were still available in the local pharmacies and in the local clinics. So the patients could access certain basic medications for vomiting or gastritis or any of the other basic medications. So as a result of this, only those adverse events which were severe, which actually needed to be managed in a hospital where the doctor had to investigate, see what's happening, they were asked to come. And most of the mild ADRs were managed very successfully. In fact, the counselors used to call the patients on the next day after the ADR was reported and managed, and the doctor had to do a follow-up call every third day to see whether the ADRs were getting better or if he needed to be reevaluated.